بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أكرم المرسلين سيدنا محمد وعلى آله وصحبه أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. Dear colleagues, we are continuing our abdominal imaging series, and we have discussed some of the issues, and now we are discussing the issue of imaging of the biliary system. And we have two main components of the biliary system, which are the gallbladder and the bile ducts. And first we'll have some information about the imaging of the gallbladder and gallbladder pathology. Then we'll discuss the imaging of the bile ducts. And the main imaging modalities include the plain X-ray, and this is an old technique known as oral cholecystography. And of course, ultrasound is one of the major tools for evaluation of the gallbladder, and sometimes we need the help of CT and MRI. And these are the lesions which will be discussed, including congenital pathology, gallbladder stones, cholecystitis, gallbladder emphysema, adenomyomatosis, porcelain gallbladder, gallbladder polyps and carcinoma and metastasis. And we have in the issue of cholecystitis the acute type, the chronic type, the emphysematous cholecystitis, and the xanthogranulomatous cholecystitis. And the gallbladder is a pear-shaped viscous, and its diameters are about 7 to 10 centimeter long, 2.5 centimeter wide, and 3 millimeter concerning the thickness of the wall. Then the gallbladder is located in the visceral surface of the liver in the gallbladder fossa, and the major role of the plain radiography is to detect one of these three issues. Number one, radio-opaque calculi in the region of the gallbladder. We know that about 10% of the gallbladder calculi are actually radio-opaque. Then calcification of the wall of the gallbladder, which is known as porcelain gallbladder, and you know that this is the precancerous condition. Then detection of air in the wall of the gallbladder or inside the gallbladder is diagnostic of emphysematous cholecystitis, which is a severe form of infection usually seen in diabetic patients. The very old technique known as oral cholecystography was done by giving some capsules. This is an oral contrast media known as biloptin, and these capsules are taken by the patient at night, and in the morning he is fasting and came to the radiology department having just plain films for the region of the gallbladder. Then during night these biloptin capsules or this oral contrast media will be concentrated by the liver into the gallbladder. Then whenever you have a plain film for the region of the gallbladder, you see the contrast media inside the gallbladder, and you can see the anatomy, you can see if there is filling defects inside the gallbladder. But you know that the major tool for evaluation of the gallbladder nowadays is the ultrasound, and this is the normal appearance of the gallbladder by ultrasound, and you can clearly identify the echo-free fluid inside the gallbladder, the thickness of the wall, and then if there are any pathologic issues. Actually, we do not need the help of CT scan for evaluation of the gallbladder in many cases, because ultrasound is good for this task. But whenever we need the CT scan, we may do some preparations such as to give the patient some oral contrast media, and we usually need to also inject the patient with intravenous contrast. And the area of the gallbladder corresponds to the area of the liver as well, and we scan the abdomen from the level of the diaphragm to the level of the iliac crest, covering the area of the liver and the gallbladder. Then you can see that this is the cross-section CT scan after intravenous contrast injection, showing the normal appearance, the distended gallbladder in the anatomic region of the gallbladder fossa, showing a clear fluid content with regular thickness of the wall. And this is MRI of the gallbladder, and of course you know that the contents of the gallbladder will be of low signal fluid, of low signal in the T1 and high signal in the T2 weighted images. These are some of the congenital lesions that we can see in the clinical practice. This is a common abnormality, which is just a symptom or a band in the region of the fundus of the gallbladder. And this is an uncommon abnormality, which is the duplicated gallbladder, which is usually seen in about 1 every 4,000 cases. Then duplication of the gallbladder is an important issue for clinical consideration, and it happens many times that the patient is coming for an ultrasound or an abdominal scan, and the result is a detection of a gallbladder stone. Then the patient says that I have removed my gallbladder once before. Then you should know that gallbladder may be duplicated, and a gallbladder may contain a stone, and it is removed either by endoscope or by surgery. Then the second gallbladder will develop another stone. And this is an example of duplicated gallbladder by CT, and the duplication may be complete or just a septum inside the gallbladder itself. One of the common abnormalities seen in the clinical practice is the gallbladder calculi. And the gallbladder calculi are found in about 10% of the general population according to the literature. And this is an oral cholecystogram showing the gallbladder distended by the contrast media with two radiolucent calculi seen as filling defects inside the gallbladder. And this is a plain fill of the hypochondrial area showing too many small radiopaque stones in the region of the gallbladder. And here you can see the typical appearance of the gallbladder stones by ultrasound. Gallbladder stones are mobile, and they produce this very characteristic posterior acoustic shadowing during ultrasound exam. And this is an oral cholecystogram showing too many faceted gallbladder stones in the region of the inside the gallbladder itself. Then some of the gallstones are cholesterol stones, and these stones may represent the majority of gallbladder calculi. And you know, the cholesterol is or belongs to the fat-containing structures, and the fat appears in the CT scan as hypodense. Then you can see two extremely hypodense calculi inside the gallbladder. And they compare the hypodensity of fat by the hypodensity of the fluid inside the gallbladder. And this is the appearance of the gallbladder calculi by CT. This is the gallbladder, and these are two radiopaque stones, and this is a frequent incidental finding during CT examinations performed for any other indications. And gallbladder stones also may contain gas sometimes, and you see this is the multiple gallbladder calculi by CT scan, and you see extreme hypodensity within the stones representing gas. This is the appearance of gallstones by MRI. This is the gallbladder, which is distended by hyperintense fluid, and this is the low signal stone inside. And you know the major advantages of MRCP in diagnosis of gallbladder and bile duct lesions. And you see this is an MRCP showing the intrahepatic biliary radicals in the common bile duct containing a small calculus. Also the gallbladder contains multiple variable sized calculi. Then the second issue is cholecystitis, and we'll discuss the acute one, the type, the chronic one, the emphysematous, and the sensogranulomatous types. Acute cholecystitis, meaning that there is acute inflammation of the gallbladder, and we have major findings or important findings by imaging. Number one is thickening of the gallbladder wall. You remember the normal thickness is about 3 millimeter, but here it may reach 1 centimeter in some cases. Then number two, you got some fluid around the gallbladder. We call it pericholecystic edema, and you may see inside the gallbladder some mud or some calculi. Then this is a case of acalcular cholecystitis without stones, thickness of the gallbladder wall, and pericholecystic edema. Then this is the appearance of mud inside the gallbladder, where you can see the very thick fluid, which is mobile also but slow, and it is of echogenicity different than the normal fluid seen inside the gallbladder. And you remember that the major findings should include thickness of the gallbladder wall and the presence of some fluid around the gallbladder. And this is a good example by CT showing a case of acute cholecystitis. This is the gallbladder with relative thickening of the wall and enhancement, and you see some fluid around the gallbladder itself, diagnostic of pericholecystic edema. And gallbladder inflammation may be associated with calculi and may not, and this is calcular cholecystitis. The gallbladder wall is relatively thickened and there is a stone inside the gallbladder. Then CT is a good technique for detection of perforations of the gallbladder, and this is a good case where you see this is the thickness of the wall of the gallbladder, and you see the defect in the wall representing the site of perforation and leakage of bile in the peritoneum in spaces around the gallbladder. In gallbladder emphysema, meaning that the gallbladder is inflamed and obstructed and markedly distended. Then you got marked enlargement of the gallbladder and the thickness of the wall. And sometimes you can detect minute air calculi inside the gallbladder emphysema. And this is a case where interventional radiology can have a role in the treatment by putting a catheter percutaneous into the gallbladder and draining this inflamed gallbladder to the outside. And this is also an example of gallbladder emphysema. You can see the gallbladder is markedly distended, the wall is thickened and enhanced, and this is an inflammation which may affect the adjacent liver parenchyma, and in many cases you can see that the liver adjacent to the emphysema is heterogeneously enhanced and maybe edematous due to inflammation. Then chronic cholecystitis means that the gallbladder is small in size, being contracted, the wall is also thickened, and you may see or may not see the pericholecystic fluid, and also you can see calculi or you cannot see. And here is an ultrasound example of a chronic acalcular cholecystitis with relative thickening of the wall. And this is a CT scan of chronic acalcular cholecystitis, and you appreciate the thickness of the wall. Emphysematous cholecystitis means that there is air in the wall of the gallbladder or inside or both, and this can be diagnosed from the plain film showing air confined to the gallbladder fossa, and you know that this emphysematous cholecystitis have a relation to diabetes. And this is an example by CT. You see the gallbladder is containing large amount of air, and you may call this emphysematous cholecystitis or gangrenous cholecystitis. And densogranulomatous cholecystitis is an uncommon inflammatory disease, and you can see that the gallbladder is distended, the wall is markedly thickened, and what's important is the presence of multiple mural nodules. And of course, this is closely similar to the gallbladder carcinoma, and it is well known that this entity of inflammation cannot, or it's difficult to be differentiated from malignancy by imaging and even by pathology. Then whenever you see that the gallbladder wall is thickened and you see masses or nodules in the wall, you have to diagnose that this is malignancy. But sometimes this gallbladder will be removed, and the histopathology will come by this diagnosis, densogranulomatous cholecystitis. The densogranulomatous cholecystitis will show these findings by imaging, and thickening of the gallbladder wall may be diffuse in the majority of cases or focal in some patients. Infiltration of the pericholecystic fat is seen in these percentages, and hepatic extension of the inflammatory condition, also biliary obstruction, and you may got some lymphadenopathy, and this will complicate the imaging finding, and you cannot be able to differentiate densogranulomatous pyelonephritis from malignancy. And this is just the case from the literature showing that the gallbladder is enlarged, the wall is appreciably thickened, and there are masses or nodules attached to the wall. And this findings can simulate very closely malignancy, but if you need the surgical confirmation in order to diagnose densogranulomatous pyelonephritis. Then we came to the adenomyomatosis of the gallbladder, and this is a non-inflammatory condition, and it is seen in about 9% of the resected gallbladders. Patients with adenomyomatosis may complain of right upper quadrant abdominal pain. And the main issue of this pathology is there is diffuse thickening of the gallbladder wall, encroaching on the gallbladder lumen with multiple cystic changes in the thickened wall. And this is the appearance by ultrasound. This is the gallbladder, and you can see marked thickening of the gallbladder wall, significantly encroaching on the gallbladder lumen. And this condition may be focal or diffuse, meaning that a part of the gallbladder may be affected and part may be free, or the whole wall of the gallbladder may be affected. And you see there is considerable thickening of the gallbladder wall with significant encroachment on the lumen. Then porcelain gallbladder means that the gallbladder wall is calcified, and this is also known in the literature as cholecystopathia chronica calcarea. And as I have said, this is a precancerous condition with about 33% malignant potential. And this pathology can be diagnosed from the plain film by detection of calcium in the wall of the gallbladder, or by ultrasound by showing evident echogenicity of the gallbladder corresponding to the presence of calcium. Then we came to the issue of gallbladder polyps, and you should know that most of the gallbladder polyps are benign, and they are made of cholesterol in most of the cases, And in order to predict that this polyp is malignant, the polyp size should be above 1 centimeter, and the wall adjacent to the polyp is considerably thickened. Then polyps are non-mobile masses inside the gallbladder. There is no posterior acoustic shadowing to differentiate polyps from the stones. Then this is the gallbladder polyp, and you see the lesion with no posterior shadowing. The differential diagnosis of gallbladder polyps is long, and it includes mainly these cholesterol polyps, which are common, but adenomas, adenomyomatosis, inflammatory polyps, carcinoma, carcinoid, lymphoma, and metastasis can be included in the differential diagnosis. As I have said, gallbladder polyps are common. The cholesterol polyps are common. They represent about 50% of all gallbladder polypoid lesions. Most of these polyps are asymptomatic with no malignant potential, and they are of course common in females. Gallbladder cholesterol polyps can be solitary, can be multiple, as you can see in this case, numerous cholesterol polyps, and you should remember there is no posterior acoustic shadowing. This is the appearance of gallbladder polyp by ultrasound, and this is by MRI T1 weighted image before contrast and T1 weighted image after contrast, indicating that the polyp is relatively vascular and it shows some enhancement after injection of contrast medium. This is the difference between gallbladder polyp and the calculi. You see, calculi are mobile, the polyps are not. Calculi will show posterior acoustic shadowing typical, and the polyps do not show this shadowing. Adenoma of the gallbladder can simulate the cholesterol polyp in most of the cases, and in order to diagnose that this is in particular is an adenoma of the gallbladder, there should be an association with other pathologies, and the most common is the gastrointestinal polyposis syndromes like familial polyposis and Bujuger syndromes. If the patient had one of these and the gallbladder demonstrates a polyp, then you may say that this is not a cholesterol polyp, but it may represent an adenoma of the gallbladder. And carcinoma of the gallbladder is a malignant mass inside the gallbladder. The mass is usually above 1 centimeter in diameter, and the wall adjacent to the mass is usually thickened. And in many times, the gallbladder carcinoma can invade the adjacent liver parenchyma. And this is an example. You see, this is the gallbladder, and there is a mass in the fundus that has infiltrated the adjacent liver parenchyma. And if you see a mass inside the gallbladder, like this one by ultrasound, and then the mass is above 1 centimeter in diameter, the gallbladder wall adjacent to the mass is thickened, then you may predict the nature of the lesion as carcinoma, and this should be confirmed by surgery. And this is the mass infiltrating the gallbladder fossa as well as the adjacent liver parenchyma. Then you can diagnose gallbladder carcinoma, and if you look carefully in the para-aortic area, you can see some of the lymph nodes. Then one of the predisposing factors for gallbladder carcinoma is the presence of calculi, and this is calcular gallbladder, and you see the wall is thickened, and there is an enhancing mass arising from the wall of the gallbladder, and also there are focal lesions in the liver representing metastatic deposits. And sometimes you cannot see the gallbladder at all because its side has been infiltrated by the mass, which has also extended into the liver parenchyma. But here you can still see the shadow of the gallbladder, and you can see the multiple masses inside the gallbladder area. Then metastasis can also occur in the gallbladder, you can diagnose the possibility of metastatic deposits whenever the patient is known to have a primary malignancy. And melanoma is one of the lesions that may or can metastasize anywhere in the body, and this is a case of melanoma metastatic to the gallbladder. And this is a case of renal cell carcinoma. The patient had nephrectomy of the left kidney, and there is an enhancing lesion inside the gallbladder confirmed as deposit of renal cancer. Then we have finished with the issues of the gallbladder, and we are now going to deal with the imaging of the bile ducts. And there are a lot of investigations also to evaluate the bile ducts, including this very old obsolete technique which is known as intravenous cholangiography is no more used in the clinical practice. And also percutaneous transhepatic cholangiography is now not used as a diagnostic technique, but used as a preparatory for interventional biliary drainage. Endoscopic retrograde cholangiography or ERCP, T-tube cholangiography is also receded recently in the clinical practice. Ultrasound and CT, MRI, and MRCP. These are the lesions in the bile ducts, including stones, parasites, cholangiocarcinoma, ampullary carcinoma, cholangitis, Belize syndrome, and finally the congenital lesions, including coloducal cysts. In cholangiocarcinoma have some types. Intrahepatic cholangiocarcinoma we have discussed in the section of hepatic imaging, single duct cholangiocarcinoma, and hilar cholangiocarcinoma, which is known as Klatskin type. Then common bile duct lesions I will show to you. And this is the normal ERCP, anatomy of the biliary system. And you see this is the common bile duct, and these are the intrahepatic biliary radicals, and this is the vein pancreatic duct. And the infusion cholangiogram was performed in the era before CT and MRI, and you can appreciate the very bad quality of the radiograph. We used to inject a contrast media by infusion known as biligraphene, and after some time we radiograph the region of the gallbladder and the liver. We may see some contrast media in the gallbladder, and you can also see the shadow of the common bile duct, and you may imagine that there are some calculi inside. But this technique was used before also the CT and MRI for diagnosis and for therapeutic issues. And we used to introduce this needle, which is known as the Chiba needle, through the percutaneous, through the right hypochondrium. We directed medially, anteriorly, and upward. Then going through the liver, and then we remove the core of the needle, injecting some contrast media. Then you have one of three possibilities under screen. Either you see that the contrast media is flowing very rapid, then you are putting the needle tip in a vessel. Or the contrast media is accumulated around the needle tip, then you are injecting inside the diabetic parenchyma. Or the contrast media is slowly progressing into a branching system, then you are in the right position and you continue injection until opacifying of the whole biliary system. And this is an example. The needle is introduced correctly into one of the dilated ducts, and you see there are dilatation of the intrahepatic biliary radicals as well as huge dilatation of the common bile duct proximal to a stricture in the distal part of the common bile duct. And this is another example. You see the intrahepatic biliary radicals are dilated, the proximal part of the common bile duct is dilated, and there is abrupt obstruction of the common bile duct, and this is usually a sign of malignancy. Then this is also a percutaneous cholangiogram. Here is the needle, and you can see that the common bile duct contains too many radio-big calculi. Of course, you can introduce some guide wires and catheters in order to drain this biliary system to the outside. ARCP is still one of the major techniques for evaluation of the biliary system, and through the endoscope you can cannulate the common bile duct and inject contrast media, and you have images to see the anatomy and to see the pathology as well. And this is the normal endoscopic cholangiogram. This is the endoscope, and here you can see the common bile duct, the intrahepatic biliary radicals, and this is the cystic duct and the gallbladder, and here you can also see the pancreatic duct. This is the appearance of dilated biliary radicals inside the liver by ultrasound, and you know that the normal bile ducts are not seen through the liver in the CT scan. Only the common bile duct is seen as a small hypodense spot within the region of the pancreatic head. But whenever you have a CT scan and you see multiple linear hypodensities going through the liver parenchyma in a post-contrast study, then you know that these are dilated biliary radicals, and you know that the patient had biliary obstruction. Then the use of MRCP is well established in the clinical practice for evaluation of the biliary system, and here you can see the normal MRCP showing the common bile duct, pancreatic duct, and the intrahepatic biliary radicals as well as the gallbladder. And this is an example of multiple common bile duct calculi. This T-tube cholangiography was performed in the era of open cholecystectomy, and after removing the gallbladder, they used to put a T-tube within the common bile duct, and the free limb of the tube is going outside the body. And before removing this T-tube, they used to send the patient for the radiology department, injecting contrast through the free limb of the tube to opacify the biliary system. And whenever the bile ducts are good and there is no filling defects through the common bile duct, they remove safely the tube. But in this case, you can see that there is a small calculus which has been missed during the cholecystectomy and slipped into the common bile duct. And this is the major role for this T-tube, is to guard against the presence of such stones to be removed before removal of the tube. Then we came to the issue of jaundice or biliary obstruction, and I have said that whenever you look to the CT scan, the contrast enhanced CT scan, and you see multiple linear hypodensities going through the liver parenchyma, and you know that these are dilated biliary radicals, and you should look for the site of obstruction and the cause of obstruction. And I will provide you an easy procedure to analyze the findings and reach the answer for both questions. Where is the site of the obstruction and what is the cause of obstruction? First of all, you should look for the dilated biliary radicals. Are they localized in a certain part of the liver and the rest of the liver is free, or they affect the whole liver parenchyma? If they are localized, then these dilated biliary radicals will be drained into an obstructed duct. And if you don't see any masses or any tumor, then you know that this should be a stricture. And according to the literature, most of the strictures in the biliary system are usually on the malignant side. Then if you see localized dilatation of the bile ducts without a previous history of intervention or infection, then you should assume that there is a stricture in obstructing the duct, draining these ducts, and the diagnosis at that time will be cholangiocarcinoma. Then if you see dilated biliary radicals through the liver, then you remember that for the malignant focal lesions in the liver, we have stated 4 common lesions, including the hepatocellular carcinoma, cholangiocarcinoma, lymphoma, and metastasis. And you remember that cholangiocarcinoma is diagnosed by the presence of an infiltrative lesion in the liver parenchyma surrounded by dilated biliary radicals. And this is the intrahepatic type of cholangiocarcinoma. Then if you see localized dilatation of the biliary radicals in a part of the liver, a segment or a lobe, then you assume that there is a stricture in the duct draining these dilated ducts, and the diagnosis here is the cholangiocarcinoma most likely. But if you see that the bile ducts are dilated throughout the liver, then what to do? If you see dilatation in the biliary radicals throughout both hepatic lobes, look at the porta hepatis. And in the porta hepatis, you can see masses like this. And you see this mass in the porta hepatis, and this is the remaining part of the mass. And actually, you know that most of the masses in the porta hepatis will represent lymph nodes. And lymph node pathology here may include lymphoma, metastasis, sarcoid, and other pathologies of the lymph nodes. But you have reached the cause and the level of obstruction. The level is at the porta hepatis, and the cause is enlarged lymph nodes, whatever the underlying pathology. If there is a known primary malignancy, you may suspect the metastasis. If there is a known lymphoma or other stigmata of lymphoma, you may suspect lymphoma, and so on. Then look at this case, and you see that this gallbladder is slightly distended. The wall is considerably thickened, especially in this area. And this is the case of gallbladder carcinoma with masses in the region of the gallbladder representing metastatic lymphadenopathy, and you see in the liver dilated biliary radicals. And then you got the site of obstruction and the cause of obstruction. The site is the porta hepatis, and the cause is metastatic lymphadenopathy from gallbladder cancer. Then look at this example. Then you see dilated biliary radicals in both hepatic lobes, and you go to the porta hepatis and you didn't find any masses, no masses at the porta hepatis. And then whenever you follow the course of the common bile duct down to the pancreatic head, you find normal findings, and there is no dilatation of the common bile duct. And then you know that there should be a stricture here, which is known as the hilar stricture, or the hilar type of cholangiocarcinoma, which is known as the Klatskin type. This is the cholangiogram, and you see the dilated biliary radicals, and you see the stricture affecting the common hepatic duct on the left side and the common one on the right side, and the proximal part of the common bile duct as well. This is the hilar type of cholangiocarcinoma, which will affect the common hepatic ducts as well as the proximal part of the common bile duct. You see dilated intrahepatic biliary radicals in both lobes and the stricture at the hilum of the liver. Then this is hilar cholangiocarcinoma, or the Klatskin type. And this is an MRCP showing the classic appearance of cholangiocarcinoma at the hilum, dilated intrahepatic biliary radicals, a stricture here and there, as well as in the proximal part of the common bile duct. Then we came to the third issue. The first issue is you see masses at the porta hepatis, then you diagnose lymph nodes and the search for the differential diagnosis of lymph node pathology. Then the second issue, you don't see any masses at the porta hepatis, then you know that this is a stricture at the hilum, and you diagnose hilar cholangiocarcinoma. Then this issue you see dilated biliary radicals, and you follow the course of the common bile duct, and you see that the common bile duct is dilated, and you go down to its terminal part, and you see one of three possibilities. Either you see a stone, or you see a tumor, or you see nothing. Then, starting by the possibility of the stone, dilated biliary radicals, and the stone in the common bile duct, and this is calcular biliary obstruction. You have reached the cause, which is the stone, and the level, which is the terminal part of the common bile duct. And whenever you are suspecting calculi in the distal part of the common bile duct, you may have ERCP, or you may have CT with reconstruction of the images along the course of the common bile duct to see a stone in its terminal portion. And this is a CT scan of the abdomen with reconstructed images along the course of the common bile duct, demonstrating multiple radiopaque stones within the common bile duct. Here you see severe dilatation of the intrahepatic biliary radicals in both lobes. Lower down you see a big stone in the proximal part of the common bile duct. Then you have reached the level and the cause of biliary obstruction. MRCP is one of the non-invasive tools used for evaluation of the biliary system, especially the common bile duct and the intrahepatic biliary radicals. Here you can see multiple calculi in the common bile duct and also calculi in the gallbladder. And this is MRCP showing a big stone in the middle part of the common bile duct, and you see this is the common bile duct in T2 weighted image, and this is the low signal stone inside. And this is another example, MRCP showing a big calculus in the distal part of the common bile duct, and this is the common bile duct in T2 weighted image, the common bile duct in T1 weighted image, and the stone is black in both images, but is well appreciated in the T2 because of the high signal fluid around the stone. And parasites are uncommon in the biliary system, but this is just an example of Ascaris worm in the distal part of the common bile duct. Then the second possibility is to detect a tumor in the region of the head of the pancreas. Then you know that pancreatic cancer, we will discuss this in the lecture of imaging of the pancreas, will in about 70% of cases will cause biliary obstruction, especially if the cancer is in the region of the head, of course. And you see dilated biliary radicals in the liver, and you see that the common bile duct is dilated, and you go down to the level of the pancreatic head and you see a mass. Then you know that this is pancreatic head carcinoma with biliary obstruction, and you got some free fluid in the peritoneum as well. And here, look at the liver, you see some dilatation of the biliary radicals inside the liver. Going down, you see that the common pancreatic duct is considerably dilated. Then lower down, you see the region of the pancreatic head identified by the superior mesenteric artery and vein. The head is enlarged. It shows heterogeneous CT density and enhancement, diagnostic of the presence of pancreatic head cancer, which is responsible for dilatation of the bile ducts and the common pancreatic duct as well. And this is the third example where there is dilatation of the intrahepatic biliary radicals as well as the common bile duct, and you got the mass in the region of the pancreatic head. Then the third possibility is to detect nothing, no stones, no tumor. And here you see dilatation of the biliary radicals, and the common bile duct is dilated. The common bile duct is dilated, also the pancreatic duct is dilated, and the common bile duct is dilated along its whole course, but there is no calculi inside, and also the pancreatic head is of normal size. Then we in the radiology department report this case as follows. We say that there is an extrahepatic biliary obstruction at the level of the distal part of the common bile duct, and this should be further evaluated by ERCP, looking for a stricture in the terminal part of the common bile duct, or the second possibility, which is ampullary carcinoma. And you know that this ampullary carcinoma is a type of duodenal cancer which is very small and is located at the site of the ampulla of water, it produces obstructive jaundice, and you cannot usually see the tumor by imaging. And here is an example. You see dilated intrahepatic biliary radicals, and the common bile duct is dilated along its whole course. The pancreatic head is normal, and there is no calculi inside. Then the diagnosis is extrahepatic biliary obstruction at the terminal part of the common bile duct. And you recommend ERCP, not MRCP. You recommend ERCP, looking for one of two, either stricture in the terminal part of the common bile duct or ampullary carcinoma. And this is an example of ampullary cancer by endoscopic image. This carcinoma is an uncommon tumor, represents about 1% of adenocarcinomas and about 5% of GIT cancer. Ampullary carcinomas can be sporadic and can be associated with other cancers in the gastrointestinal tract, especially the colorectal cancer. This is the solid mass protruding into the second part of the duodenum, centered to the region of the ampulla of water. Then you got dilatation of the pancreatic duct as well as the common bile duct. Then if you try to locate this ampullary cancer, it's hard to see this carcinoma by imaging, but this is a case obtained from the literature, and you see dilated intrahepatic biliary radicals. The common bile duct is markedly dilated, and also the pancreatic duct is dilated. Going down, and you see there is considerable this is part of the duodenum, of course, and you see a mass inside it. And the reconstructed image will show that this is the common bile duct, and this is the pancreatic duct, and this is the tumor which is bulging into the duodenum. Then look at this case. There are dilated biliary radicals throughout the liver. The common bile duct is dilated. The common bile duct is dilated, and you can imagine that this is the site of the tumor or the ampullary carcinoma. It's better for this to be evaluated by ERCP, not by MRCP. And here is another example: dilated intrahepatic biliary radicals, dilated common bile duct, and the common pancreatic duct, but the pancreatic head is good, and there is no calculi inside, and the endoscope shows a mass which is centered to the region of the ampulla of water. Then you may got a stricture in the terminal part of the common bile duct, and you remember that most of the strictures are usually on the malignant side, provided the clinical data and there is no previous intervention or any predisposing factor for other strictures like inflammatory types of the stricture. Then this is the stricture in the terminal part of the common bile duct, and this is another case by BTC showing a filling defect, polypoid filling defect in the common bile duct, representing cholangiocarcinoma. And Merizi syndrome is one of the rare complications of chronic calcular cholecystitis. This syndrome means that there is a gallstone that has been impacted into the cystic duct or the Hartmann pouch or near to the neck of the gallbladder. This stone will create some inflammatory reaction, compressing this part of the bile duct with consequent dilatation of the proximal intrahepatic biliary radicals. The Merizi syndrome is difficult to be diagnosed by imaging unless you put in your mind that this is one of the possibilities for biliary obstruction. And here the issues are, number one is to detect biliary obstruction at the level of the common hepatic ducts. You see dilated bile ducts in both hepatic lobes. And you see that the gallbladder contains calculi, because one of these calculi will be impacted near the neck of the gallbladder, compressing the proximal or the common hepatic duct with proximal dilatation of the biliary radicals. Then a stone at the level of obstruction, and this stone is better detected by CT, and occasionally an enhancing inflammatory mass surrounding the stone, representing the cause of biliary obstruction. And this is reconstructed images from MRCP showing calcular gallbladder, and this is the site of the stone compressing the common bile duct. This is the 3D image showing the calculi in the gallbladder as well as the site of compression. And this is, of course, a reasonable example of Merizi syndrome by CT. Dilated intrahepatic biliary radicals, the gallbladder is chronically inflamed with thickened wall and enhanced wall. Then you see the stone and in the region corresponding to the site of the common hepatic duct, and is suspected to be surrounded by some inflammatory granulation tissue representing the cause of obstruction. Then we came to the issue of inflammatory cholangitis. You know that this cholangitis may present in the clinical practice by two major items. Number one is biogenic or oriental cholangitis, and the second one is the sclerosing type of cholangitis. According to the literature, the biogenic cholangitis is essentially found in Southeast Asia and is caused by this infestation, the hepatobiliary parasite, and this parasite will initiate inflammatory reaction, and this reaction will cause some strictures and will lead to also the formation of calculi inside the biliary system. Then the pathology is the fluke acts like an nidus for stone formation. The fluke causes a stricture, aids which to the stone formation as well. The inflammation initiated by the fluke and the formation of the stones both will lead to some biliary obstructive changes. And this is the clinical presentation: right upper quadrant pain, recurrent fever and jaundice, leukocytosis, elevation of the alkaline phosphatase level and serum bilirubin. The diagnostic findings for biogenic cholangitis or even sclerosing cholangitis is to detect multiple biliary strictures alternating with dilated bile ducts, and the presence of calculi inside the dilated biliary radicals is suggestive of biogenic cholangitis rather than sclerosing cholangitis, although the sclerosing cholangitis may be associated with some percentage of stone formation as well. This is the case of biogenic cholangitis, and you see dilated intrahepatic biliary radicals with calculi inside the dilated bile ducts, and you may even see some small biogenic abscesses in the liver containing air fluid level. Sometimes you cannot see the stones inside the dilated biliary radicals by CT because they are made of cholesterol, and you know cholesterol is of hypodense texture, and the fluid also is hypodense, and they may be difficult to be detected. But this is one of the advantages of MRI, to detect the calculi inside the biliary radicals, confirming the diagnosis of biogenic cholangitis. And if you see, as I have said, multiple biliary strictures and dilatations, you know that you are dealing with cholangitis. And if you see stones, you may prefer the diagnosis of biogenic cholangitis, although the sclerosing cholangitis may be also associated with some percentage of calculi. And the role of MRCP is well known for the diagnosis of cholangitis by detecting multiple biliary strictures and dilatation. And they know that intrahepatic biliary calculi are seen in about 8% of patients with sclerosing cholangitis. an MRCP examination showing the appearance of cholangitis with multiple strictures and dilatations, giving the beaded appearance of the biliary radicals. Then detection of air inside the biliary system is known as pneumobilia, and pneumobilia is usually the sequelae of previous endoscopy or the presence of application of biliary stents or surgery doing choledochogerostomy, for example, or the passage of stones from the common bile duct into the duodenum, and also maybe the sequelae of infection, and finally malignant fistula between the biliary system and the gut may lead to the leakage of air inside the biliary system. Colorectal cyst is the congenital abnormality affecting the common bile duct, and you have too many types of this colorectal cyst. And this is just a drawing or diagrams to show the different types of colorectal cyst you can see in the clinical practice. The first one is the type 1, which is a fusiform dilatation of a part or even the whole common bile duct, like this one. And type 2 is diverticular outpouching from the extrahepatic biliary radicals. Type 3 is the focal dilatation of the distal part of the common bile duct, which is known as cholodococele, and is usually similar to the erythrocele in the ureter. Type 4 is dilatation of the intra and the extrahepatic biliary radicals. Type 5 dilatation of the cystic dilatation of the intrahepatic bile ducts, and this is known as Carolic disease. This is type 1 colorectal cyst, where the common bile duct is fusiform and diffusely dilated. This is type 1 by diagram and by MRCP. Type 2 is a diverticular outpouching from the common bile duct. The common bile duct is of normal caliber, and this is a diverticulum coming from the middle part of the common bile duct. Cholodococele is dilatation of the terminal part of the common bile duct, as you can see in this example. And type 4, multiple dilatations of the intrahepatic, as you can see, as well as the extrahepatic biliary ducts. Type 5 is Carolic disease, where there are multiple cystic dilatations of the intrahepatic biliary radicals, but the extrahepatic bile ducts are of normal caliber. This is an autosomal recessive disease and may lead to recurrent attacks of cholangitis, fever, and jaundice. And whenever you have imaging of the patient by CT, and you see this classic appearance, which is known as the central dot sign. And the central dot sign represents the portal venous radical within the cystically dilated biliary radicals. And you see here that there are multiple cystic dilatations of the bile ducts. And one may say why I shouldn't consider this as multiple hepatic cysts in a course of polycystic disease of the liver, for example. Number one, in order to predict that these are belonging to the biliary radicals, you see tubular dilatation of the bile ducts through some parts of the liver, then you know that this should be bile ducts as well. Then the presence of the central dot sign, which is not seen in the cystic disease of the liver, is also one of the suggestive criteria of Carolic disease. And this is a classic appearance of Carolic disease, where you see multiple cystic dilatations of the intrahepatic biliary radicals, as well as tubular dilatation of the bile ducts in some areas of the liver, with the classic central dot sign seen in most of the cystic lesions. هذا وبالله التوفيق والحمد لله رب العالمين والسلام عليكم ورحمة الله.